This morning we have Dr. Ruah-Hain, who is a gynecologic oncologist at the University of Texas MD Anderson Cancer Center. He is originally from Mexico City and received a medical degree from the Universidad Panamericana School of Medicine. After graduating from medical school, he worked at Massachusetts General Hospital, looking at biomarkers for early detection of preeclampsia. He then completed obstetrics and gynecology residency at MGH and Brigham and Women's Hospital. And then following that, a fellowship in gynecologic oncology, also at MGH. He completed a Master's of Public Health at Harvard School of Public Health and a postdoctoral fellowship in the program for Cancer Outcomes Research Training Program. He then served as faculty in the Division of GYN Oncology at MGH and Harvard Medical School before now joining the faculty at the University of Texas MD Anderson Cancer Center, where he's now an assistant professor in GYN oncology, as well as the Department of Health Services Research. His interests are in the areas of surgical treatment for gynecologic malignancies and rare tumors, as well as strategies to reduce disparities in GYN cancer care, as well as in care for young women with cancer. So we're very excited and pleased to have you here join us.
And Alejandro, before you start, I just want to say a couple words to the crowd. I've had the good fortune to intersect with Alejandro on several national fronts, and I'm just a big fan of his work. And he does more than what he's talking about here. He's involved in a multi-center clinical trial right now that we're participating in. And just to comment, the work that Alejandro has done with cancer care disparities is really remarkable, and has interfaced with Ryan Spencer and a few others in the division. And on top of all that, I've developed a love of Mexico City through Alejandro. So we're so glad you're here, Alejandro. Go ahead.
Awesome. Thank you so much for the super kind words. And I'm very, very excited to be here. And so today I'm going to talk about moving beyond the identification of cancer care disparities and how we can untap the potential of health service research to try to diminish those disparities in cancer care. So we have a little bit of issue with the presentation. So I'm going to be just saying next. So that's just a small glitch, but we're going to make it work for everyone. And if anyone has any questions, this is very informal. Feel free to stop me. I know that with virtual presentations, it's always a little bit weird, but again, feel free to stop me at any point. Next. Amy, can you put the next slide? Okay. Next, I have no disclosures. Next. Okay. So as we talked before, I'm originally from Mexico, and eventually moved to Boston and did my residency. And I had the good fortune to work with Ryan Spencer, and we were co-residents together. And then after that, I stayed there for fellowship and faculty, and eventually I moved to Houston. And next, one of the main reasons I moved to Houston was for the opportunity to work at MD Anderson. But the next slide, please. In particularly to work at LBJ Hospital. So LBJ is one of 2 county hospitals in Houston. And what is very, very interesting about LBJ is that all the cancer care is provided through MD Anderson. So all the faculty, nurses, nurse practitioners, pharmacists, all of them are actually MD Anderson employees. And all the chemotherapy is provided through MD Anderson. So it's a very unique situation in which patients that are uninsured or have like low insurance can receive care very similar to what we can provide at MD Anderson. So it's a very interesting place, and three faculty from the Department of GYN Oncology go there. And it's just a fantastic experience. We have fellows that go there, and I think we do a very good job at providing, again, very similar service to what we can provide to MD Anderson's, to a population that it's medically underserved. But that was one of the main reasons I really moved to Houston, because if I was interested in disparities, I really wanted to be in the forefront to really understand what was going on. So I'm going to start with a case. Next slide, please. So the all important thing, just to when we talk about disparities, is just about the definition, and this is the definition that I like the best. This is from the Institute of Medicine report on unequal treatment. So disparity is a difference in healthcare quality, not due to difference in healthcare needs or preference of the patient. And I think most of you have seen some iteration of this picture in which we compare equality to equity, and equality is not the same as equity. And what this picture is trying to show is that it might be that it's not only providing the same level of care, it's making sure that everyone has similar, can achieve the highest level of health. So it's possible, and it's likely that what happens is that some patients definitely require more resources in order to achieve that level of health. Next slide. So this is a case. This is one of my first patients that I saw when I moved to Houston and I started working. So this is other pretty healthy who underwent a surgery for an ovarian mass at an outside hospital. And she had a stage 1 procedure, and the pathology showed a stage 1A mixed germ cell tumor of the right ovary and had some high-grade components. So, and this was back in December of 2017. So the patient was referred to me, but I saw her 3 months later. So when we saw her in clinic, it was very clear that she would require chemotherapy based on the high-grade component. And my fellow at that point very smartly suggested getting a CT scan. And we did CT scans of chest, abdomen, and pelvis. And unfortunately, the CT scan at that point, 3 months after her original surgery, showed already carcinomatosis, a 20 centimeter pelvic mass, and diffuse lymphadenopathy. Next slide. So a couple of days later, she was admitted to the hospital, an outside hospital, with acute renal failure and a DVT. And then 3 weeks later, she had PCNs, peritoneal tubes placed based on for urinary obstruction, and she was admitted with urosepsis to our hospital. At that point, it had already been 4 months since her original surgery, and it was very clear that she was progressing very fast. So we made the tough decision that at that point, after the urosepsis had resolved, to start her on chemotherapy. So she got her first cycle of BEP. She actually received growth factors, but despite of the growth factors, she had severe pancytopenia. And eventually, after this admission and chemotherapy, she was discharged home. And unfortunately, she came back 1 week later with neutropenic fever and had a very complicated course and eventually died. So, this case really is a young patient, 36-year-old, with early stage germ cell tumor, that these tumors are very, very chemosensitive, that despite that, ended up dying. And, we're going to go through the different causes of why this could have happened. Next. So it's interesting that, looking back, this is Emily Hinchley's paper. She's a fellow right now at MD Anderson, but we worked together when we were both in Boston. And she published this paper showing that in patients with germ cell tumors, just like our patient, those with advanced stage disease, those that are African American, had worse survival compared to those that are white. Interestingly, the patients that had early stage like our patient did not have difference in survival. But to me, that's always, always resonated that, we kind of would have thought that our patients might not have the best outcome based on this, our previous findings. Next slide. But this is not unique to germ cell tumors of the ovary. This is the first paper that we published with Marcella and John Shorgy when I was a fellow. And the hypothesis for this paper was that there's been a lot of research and intense resource implementation for improving cervical cancer screening in the United States, and also in particular for medical underserved patients. So the hypothesis was that so many resources were utilized to diminish, to improve cancer screening, that maybe the rates of mortality for patients that are medical reserve, or particular African Americans in general, would have disappeared over time. And what we saw is that these disparities in cervical cancer cervical cancer survival have remained pretty much over time. And this is a study from the SEER database. Next slide. But again, this is not particular for only cervical cancer. This is a project that we did with Dr. Rice and Dr. Spencer, in which we analyzed the SEER data and also NCD, the National Cancer Database. And we tried to do this temporal analysis of all GYN cancers. And as you can see, these survival differences between African Americans and white patients have remained for ovarian cancer, cervical cancer, and endometrial cancer. I think there are two interesting things in this slide. In the red line, you can see that those are Hispanics. And Hispanics, you would think that when you look at the data, they receive less adequate treatment compared to white patients, but their survivals in a lot of the cancer sites and a lot of studies are not that different between Hispanics and whites. So there is this Hispanic paradox that people have talked about for many years, and there's multiple reasons or why this could happen. One of them is that a lot of the Hispanics, when they are at the end of life, they decide to move back to their countries and die there. So I have a lot of patients in my clinic at LBJ that are from Mexico or other parts in Latin America that when we reach that point of end of life, they actually want to go back to their families. So that's one of the reasons why we might not be capturing these differences between Hispanics and whites. But it's very clear that in African Americans versus whites, there's a different survival, except for vulvar cancer. And we have published a different paper, just particular for vulvar cancer, in which we replicated these findings that this is one of the few cancers in which African Americans do not do worse than whites in terms of survival. Next slide. So why are patients that for minority races are having worse survival in terms of worse survival? So definitely patients with cervical cancer and endometrial cancer do present with advanced stage disease among African American patients. And you can see patients that have, this is a study from SEER from cervical cancer that I showed before, they do present with higher rates of advanced stage disease compared to whites. And also in patients with endometrial cancer, it's very clear that patients that are African American present with advanced stage disease compared to whites. The other thing that it's particular for endometrial cancer among African American patients is that they have high rates of high-grade carcinomas, particularly uterine serous carcinomas, uterine carcinosarcomas. Next slide. This is also for vulvar cancer. Patients with vulvar cancer do present with high advanced stage disease. Next slide. So we have talked about worse survival and that they present with advanced stage disease, and other investigators have postulated that maybe it's also related to difference in treatment. So this is a manuscript that Dr. Ruah-Hain, who's a former fellow from University of Wisconsin, published a couple of years ago, in which what he was trying to do was in patients with locally advanced cervical cancer, he wanted to show whether there had been any difference in standard of care treatment with chemotherapy and radiation followed and brachytherapy. And what you can see in the first figure is that Hispanics and African Americans receive less adequate treatment for cervical cancer in locally advanced stage disease. Next slide. And then when he looked at the temporal trends, it was very clear that these differences and disparities have remained over time as well. Next slide. And we have documented the similar trends in ovarian cancer. In this slide, like the last column in each of the figures are white patients, and the second column are African Americans, and as you can, and the third column are Hispanics. And as you can see, for different treatment options for ovarian cancer, it's very clear that either African Americans or Hispanics receive less adequate treatment for ovarian cancer. Next slide. So I think there's a lot of investigators that really think that the main difference between races, racial and ethnicities in terms of survival, it's mainly due to access to care. in terms of they present with a later stage and they receive less adequate treatment. And there are different papers in GYN cancer in which investigators have taken populations that go to, patients that go to the military, in which all they receive the same level of care, and there are no differences between African Americans and whites. So I would say that there's a little bit of true about that, but I think that is not the complete story. I think, to me, it's a much more complex story about why the different races or medical underserved patients have worse survival. And it's not only about the treatment once they get cancer, and that they present an advanced stage disease. There's other things like the environment, the epigenome, and behavioral social factors that really come into play. So I love this figure from Kemi Dole, who's also GYN oncologist at University of Washington, Seattle. He does an amazing job in trying to elucidate these kind of disparities among African American women, in particular endometrial cancer. But in this figure, as you can see, really these disparities potentially start happening even in pregnancy and definitely throughout the livelihood of patients. So, we all know that education, health literacy, care access when you're young definitely has an impact once these patients that eventually are going to develop cancer, how they're going to interplay in their prognosis. And once they reach out, once they become adults, their comorbidities, whether again health literacy, the job, transportation, all of these things come into play to really, to lead to worse survival. So just going back to my patient that came to LBJ, you can think it was not only a 36-year-old that came with presumably early stage. If you go back more to his history that I didn't share, is that, again, it took 3 months for her from a private doctor to come to my clinic. Part of it was because she didn't understand very well what was her diagnosis and what was importance of chemotherapy. The other thing is that she had transportation issues. She had 2 kids at home, and she could not leave the kids by themselves, and she could not pay for childcare. So all of those things that happen in the background that we sometimes do not know they exist really have a significant impact in these differences in survival. So it's not only about advanced stage and treatment. It's all of those things that have happened in the prior 30 or 40 years on our patients' lives. Next slide. So this is how I look at disparities in my brain, and there are different areas in you can study disparities, all the way from diagnosis to end of life, prevention, and so forth. So next slide. So once I moved to LBJ, I decided just to focus in 2 particular areas, in prevention, screening, and fertility access. And the reason I picked prevention and screening was because it was really clear to me that, at least at LBJ, that we could provide the same level of treatment compared to MD Anderson, but still patients are getting worse outcomes. So to me, one of the best ways to try to diminish these disparities is really to preventing the cancer or trying to do better screening. So next slide. So for the next couple of slides, I'm gonna show or talk about some of the projects that we're doing right now at MD Anderson and LBJ in terms of prevention and screening. And I'm not gonna show a lot of data. I'm gonna show more work in progress. And I'm hoping that with what I'm discussing, it can help other areas in other areas in OBGYN that can be implemented, like the research techniques that we're using can be implemented in other areas of OBGYN, because these disparities in healthcare are not unique to cancer, are pretty much permeated in all types of in healthcare delivery. Next slide. So in terms of screening, it's very clear, and I don't think I can convince you that there are significant disparities in screening between groups. For example, women in the highest income bracket are 19% more likely to be up to date with cervical cancer screening than women in the lowest income bracket. Or foreign-born women in the US are twice as likely to have never had a mammogram than US-born women. So as you can imagine, these screening disparities are very common. Next slide. So what I'm gonna talk about, I think there's been a lot of research about cervical cancer screening and prevention. So what we have decided to focus is more about prevention of hereditary cancers, particularly for BRCA and Lynch syndrome. Next slide. So I think this is a very interesting study. So this is a study in which it was a randomized controlled trial in which they wanted to compare usual care. What they meant with usual care is a patient that was eligible or that the standard of care for those patients was to get some genetic testing, for example, ovarian cancer or certain patients with breast cancer. And they went to usual care just talking to a genetic counselor or a physician about getting genetic testing. And they compared that approach to doing, instead of coming to the office, to telephone counseling. And I think what is very interesting about this study is when they look at white patients, okay, and those are our minorities and mostly are African Americans and some Hispanics, like it's very clear that the usual care, there was no difference in getting tested in the usual care, but when they compare the telephone counseling, patients in the minority group were less likely to get tested. So what this means to me is that very clearly that whatever interventions we designed have to be tailored to specific populations. Not what works with one specific population is going to work with different patient groups. Next slide. So what we are focusing right now in our research is cascade testing. So cascade testing means that once we identify a patient with a genetic mutation for hereditary cancers, and I'm going to talk about now particularly for BRCA. So let's say that we have a patient with ovarian cancer and we do genetic testing and they have a BRCA mutation. So their family members have at least 50 or more or less 50% chances of having the same mutation. And if they have the mutation, then the risk of having ovarian, breast, and other cancers is pretty significant. So it is very, very important to identify those family members because those family members are at a significant high risk of having the mutation and therefore having the mutation. So cascade testing means once you identify that index patient with a mutation or the proband, how can you reach out to the family so the family, or at least the first degree relatives and second degree relatives, can be tested for the genetic mutation. So right now, what happens in clinical practice, at least at MD Anderson and at LBJ, patients that are identified with a genetic mutation, they go and talk to a genetic counselor, they go extensive counseling, and then at the end, they receive a letter in which they and the genetic counselors talk to them about the importance of cascade testing and so forth. And they also receive a letter that in which the family, in which we tell patients that they have to share this information with family members. So all of this sharing information, all of the burden of convincing the family members is all into the patient. So as you can imagine, the patient has to assimilate the information and then share with the family. Next slide. The problem with this strategy is that despite the fact that 80% of the times the proband or index cases shares the information with the family members, only between 20 to 50% of the family members actually get tested. And those rates of 20 to 50% that I'm talking about are studies done in academic centers where mostly are white patients of high socioeconomic status. We really don't know what is happening in medical underserved communities, but it's very likely that it's less than 20%. So next slide. So this is kind of a diagram of what happens when a patient is diagnosed with a BRCA mutation, for example. So the patient is identified. Then a second point, the patient receives the mutation, has to understand the information. And then importantly, as number 3, the index patient has to share that information with the family. And then number 4, the family has to receive the information, understand the information. And then once they understand the information, they also need to act on that information and figure out to what clinic or how to get tested. So you can imagine how at these different steps, all of this information can get lost, leading to very poor rates of cascade testing in this country. Next slide. So this is a study that we are doing with Karen Liu and Erica Bedner. Erica Bedner is a genetic counselor at MD Anderson that is helping me with all of these studies. And this study is a mixed method study in which we are trying to identify what are the barriers that the family members face in order to get cascade testing in medical underserved areas. So we're doing a lot of deep interviews, talking to the probands and then the family members to really dig in why they are not getting tested, to try to understand that, because at the end of the day, what we want to do is create an intervention to improve the rates of cascade testing in medically underserved areas. But if we don't understand the barriers, just like the example that I gave about the telephone counseling, it's very likely that this is not going to work. So again, this is, I think, very important to really go to the basis to really understand what are the barriers that these patients are facing. Next slide. So this study is being done at it's at MD Anderson, LBJ. We're collaborating with the University of Alabama, Birmingham, with Trey Lee, who's a GYN oncologist, and Isabel Scarinci, who's a behavioral scientist, and she's been my mentor on this project. And also we're collaborating with the Rio Grande Valley. And the Rio Grande Valley is the southeast portion of Texas that most people in that area are undocumented, and it's a very rural area that's medical, very low, that has very low resources and very low access to healthcare. So what we're trying to do is at LBJ trying to capture medical underserved patients that live in a urban setting. In the Rio Grande Valley, what happens with Hispanic patients that live in a rural setting. And then in Birmingham, Alabama, we're trying to capture African Americans live either in rural areas or rural or urban areas, to really try to have this whole picture about what is happening in these different populations in terms of barriers to access to cascade testing. Next slide. So, but these are not the only studies that we're doing for cascade testing. This is a study from my collaborators in all this research in cascade testing. So she published this paper in JCO. And what she did is, she works at Cornell. In her practice, she identified 30 programs, 30 patients with genetic mutation. Most of the patients had a BRCA mutation. And what she did is that for each of the patients, she asked whether she could contact their family members. She asked the program for permission, because you can imagine that this is an ethically very challenging how you can share the information with family members. And that's one of the issues with cascade testing, is that, and I forgot to mention this before, is that you are not, as researchers, we're not able to reach, or physicians or clinicians, we're not able to reach out to family members directly, because it might be that the family members do not want to know the information. So we first have to ask programs whether we can reach out to family members, and we have to make sure that the program has told them about the fact that they are potential risk of having the mutation. So before we can actually reach out to them, we have to make sure that the program at least has shared that information with the program. So in this study, what she did, again, she took 30 patients in her clinic with a genetic mutation, and then after permission, she reached out to the relatives, and she was able to contact 114 relatives or phone numbers of family members that she got from the programs. She was able to contact 95. She contacted them, talked to them about the importance of cascade testing, and then offered free testing for them. And what she was able to achieve cascade testing in 70%, or genetic testing in 70% of the family members that she was able to reach. When you look at, and this is 70% of the 95 patients, when you look at the 114 potential patients, the rates are 58%. What is interesting is 41% had a mutation. So again, those are patients that it's very important to identify, because those are patients that are at significant risk of eventually having cancer, that we can offer them prophylactic surgeries or screening. So these rates that she showed, 70%, are the highest rates that have ever been published in terms of cascade testing. So next slide. So right now we are conducting the FACT trial, and this is a trial that we're doing at MD Anderson, Cornell, Columbia, and Duke University. And the pictures are from my fellow Ronnie Nitecki, who's running the trial, along Melissa Frey, and Haley Moss from Duke and Alex Melamed are co-PIs at their institutions. So from this study, what we're trying to do is try to emulate what Melissa was able to do at Cornell, a single institution, where we can do it at a larger scale in a randomized controlled trial. So patients with a BRCA mutation are going to see the genetic counselors at the different institutions. If they're randomized to the intervention, they're going to see a video, and then we're going to mail them a saliva kit, and then we're also going to call them to remind them about the genetic testing. Next slide. We're going to prove next. Next. Sorry about this. So the primary objective of this trial is to really compare the rates between genetic testing among those that received the intervention and the control group in patients with BRCA mutation. And we also evaluating other secondary outcomes. We want to see whether, what are the rates of positive testing? We want to see whether this kind of intervention produces stress to family members. And we also want to evaluate whether these patients that are tested, what kind of surveillance or prophylactic interventions they have undergone. Next slide. Next. I'm so sorry about this. Next. Perfect. So this is the prior one, please. So this is the design of the study. So as you can see, the program comes to clinic and they're randomized either to the intervention or the control group. The control group, it's just the usual care. They come to clinic, they talk to genetic counselor. The genetic counselor mentions cascade testing, gives them the piece of paper that we talked about initially that refers them that they need to discuss with a family member. In the paper, we also offer genetic testing for free for the family members, because we don't want to say that the reason why the intervention worked was because we were offering free testing. So even if they are in the control group, they can also get the testing for free. And some companies actually offer the testing for free for family members as well. And then we call them 6 months later to the control group to see whether they got testing. We don't want to call them before we don't want to contaminate the intervention. And then the patients are in the intervention, they receive phone calls, they get the video, and then they receive a link to get the free testing. And then eventually, we're also going to call them 6 months later just to make sure that they underwent testing. And then if they underwent testing, we want to know whether they had like the stress or they had this significant distress because of the testing and so forth between both groups. Next slide. So I hope that after talking about these issues with cascade testing, I was able to convince you that this is an issue that we're facing, and it's only going to get worse in the sense that now in GYN oncology, we're doing more and more genetic testing, so we're identifying more programs. And if we don't proactively try to figure out how we can access medical underserved patients with genetic testing, we're going to lag way behind. And I'm not talking about what happens at University of Wisconsin. I'm really talking about what happens in really rural areas in Wisconsin, rural areas in Texas, in small clinics. Those are the patients that are really not getting tested, and the family members that are not really getting tested. So the whole goal of all of these studies that we're trying to do is really to try to create an intervention that somehow we can really access those medical underserved patients or difficult to reach patients to really get them access to genetic testing. So the work that we're doing with LBJ, UAB, and Rio Grande Valley is going to provide that quality work to really understand how the intervention might look like. The FACT trial is helping us to try to identify, and kind of like it's an exercise for us to see whether calling the patients, how that infrastructure is going to work in a much larger randomized controlled trial in clinics, in patients in rural areas or medical underserved areas. And then Karen Lou has done tremendous job. Karen Lou is the chair of GYN oncology at MD Anderson, and she's done tremendous work in this area. And she just recently finished the Magenta study in which the intervention was, how can we reach genetic testing at home for everyone? So we're trying to gather all those experiences between all of these groups to really come up with an efficient intervention for medical underserved patients. So we have two projects that we are in the work of developing. The first one is Ignite TX. It's Increased Genetic Hereditary Cancer Testing in Texas initiative. So it's only focused in Texas. And the other one is that we're planning down the road, like in 3 or 4 years, is the Ancestor trial, really doing a randomized controlled trial, very similar to the FACT trial, but only in rural areas around the country. So next slide. So the Ignite initiative is something that I'm developing along Karen Lou and Erica, and hoping to work with other sites in Texas. And what we're hoping is, how can we improve the cascade testing along Texas? So we're partnering with all clinics along Texas and with different companies to really try to get access to those programs so we can reach out to their family members. And the rationale for this is, you can have, and you can see the first figure is that, let's say that you have you can identify all the patients, or you know that all these patients with genetic mutations exist in Texas. But currently, only 30% of the patients are identified, right? Only 30% of the index cases are identified in these healthcare systems like MD Anderson, UT Southwestern, or the UT Health System or all. And even if you have a very successful intervention, let's say that your intervention is like it's a silver bullet, like works in 90% of the patient. If you only reach out to 30% of the patients, that means that you're only really testing 25%. I think what we really need is how can we reach out to a higher number of index cases, right? Because if you reach out to a higher number of index cases, even if your intervention is not as successful, let's say it's half successful, but by the fact that you're reaching out to a higher number of index cases, you're going to be ended up testing an overall larger number of patients or family members. So that is kind of the rationale. So we, instead of like focusing on what happens in each clinic in Texas, we're trying to go, how can we work with the government, how we can work with clinics, how we can work with genetic companies to really have access to the information about all the new cases, index cases that are diagnosed in the state of Texas. So then we, in a group, can reach out to the family members overall. Next slide. So I talked about screening and prevention, what we're doing. And now I'm going to talk about a little bit different topic in terms of disparities. And another area that I'm very, very passionate about is how can we improve access to care to young women with cancer. So next slide. So in particular, I'm very interested in how can we improve sparing procedures for young women with cancer, and how we can help them if they undergo fertility sparing procedures, how we can improve their access so they can achieve successful pregnancies down the road. Next slide. So this is a study that we did with Alex Melamed a couple of years ago. And this is just to highlight that for patients with early stage ovarian cancer that undergo fertility sparing procedures compared to those that undergo the conventional treatment, there's pretty much, for the well-selected patients, there is no difference in survival, suggesting that fertility sparing procedures are safe in women for specific group of women with early stage ovarian cancer. Next slide. So this is part of a career development award, a K award that I have. And with this grant, what we're trying to figure out is among patients with breast and GYN cancers, through linking several databases, figure out whether achieving a pregnancy, not only that you're undergo fertility sparing procedures, but that you actually become pregnant, whether that leads to worse prognosis. And also, we want to evaluate whether women with breast or GYN cancers have worse obstetrical outcomes compared to controls. And the reason we're doing this is because, first of all, there's very limited data. Most data is from single institution experiences. But second is we think that if we can provide this information to patients and providers might feel safer to offer fertility sparing procedures, and also encouraging their patients that it's safe to get pregnant. Next slide. So as I mentioned, all the studies about fertility sparing procedures and OB obstetrical outcomes have been published from single institution series. So the data is very, very sparse. So what we wanted to do was, how can we look this in a larger population? And hope I'm hoping that this makes sense, because I don't have the opportunity to show each of the squares. But what we're doing is we're linking several databases in California. So every patient that in every state, every patient that is diagnosed with cancer is logged into a cancer registry. And in California, it's like a third of the population in the United States. So we're working with California because it's a large population, and it's very easy to work with the California Cancer Registry. So every patient that is diagnosed with cancer in California is logged into the California Cancer Registry. And the California Cancer Registry has rich data about their diagnosis. So we have information about what type of cancer they had, breast or ovary cancer, endometrial. We know their histology, we know their stage, we know their grade, we know what they treatment received, what surgery, what radiation. And also, more importantly, we also know their survival or their follow-up. But it's very important for these types of analysis. So there's a separate database in California that's called the OSHPA data. So every time a woman gets pregnant in California and reaches more than 20 weeks, they get logged into this database. And this database, again, includes all pregnant women in California, and you have information about their OB outcomes, such as birth weight, gestational age of delivery, whether they have neonatal or maternal complications, and so forth. So we were able to link this California Cancer Registry to the OSHPA data based on date of births and social security numbers. And all of this process is complicated. It has taken 2 years to do these linkages because there's a lot of regulatory components. But you can imagine now that we have now identified patients that have history of breast or GYN cancer, and now we can tell whether they got pregnant afterwards and what happens to their pregnancies. We also know if they had a pregnancy and they had cancer afterwards as well, or if they had cancer during pregnancy as well. So you can analyze all of these different groups. What the group that we're the most interested are those patients that had cancer and eventually got pregnant. Okay. On top of that, we are working with the SARCOS data, so the Society of Assisted Reproductive Technologies, clinical outcomes data. So every time a woman undergoes an IVF cycle in the United States, it gets logged into this database, and I think it includes more than 92% of the IVF cycles in the United States. So again, after a lot of conversations and discussions and the help of Valerie Baker from Johns Hopkins, we are linking this data to the OSHPA data and to the California Cancer Registry. So now we know if a patient with cancer had pregnancy and whether they required IVF in order to get pregnancy. So that's an important variable that we didn't have. So we're getting that we have linked that data as well. So we know whether they had IVF, but also we know if someone with cancer that did not get pregnant got IVF. So we can analyze that as well. And we have a bunch of control groups of patients that never had cancer, and we know whether they got IVF or not. So you can imagine all different analyses that you can do with this linked data. And this is just pictures of my collaborators. The first picture is from Nancy Keating, who's been my mentor for many years. She's at Harvard healthcare policy. Chong is my analyst, and Jose is a PhD economist and statistician who's helping us with this complicated analysis. Next slide. So next slide. So the first analysis or project that I want to show to you is the first project we want to do is breast cancer. And the reason we're picking breast cancer is because there's a very large number of patients with breast cancer, and we can, therefore we have higher outcomes. So what we want to do with this project is to figure out if patients with breast cancer that achieve a pregnancy later on have the same prognosis as patients with breast cancer that did not achieve pregnancy. And the rationale behind it is because pregnancy increases hormone, estrogen and progesterone increases during pregnancy. So there's always been a fear in the medical oncology community that pregnancy can increase the recurrence in breast cancer and therefore lead to higher mortality among patients with breast cancer. There's a couple of studies out there that have shown that getting pregnant after breast cancer is safe. The larger studies is around 300 patients. So this is what we're trying to do is in a larger study, in a population-based study, whether, again, breast cancer, pregnancy leads to worse prognosis. And on top of that, none of those studies really have control whether patients had received IVF or not. So the first line is the exposure group. So let's say you have a patient with breast cancer, and then that patient has a date of delivery, so that means that she had a successful pregnancy. And then we want to compare that to breast cancer patients that did not achieve pregnancy. But there's a big selection bias that happens, the healthy mom effect, right? So if you have breast cancer and you achieve a pregnancy, that means that if your pregnancy was 4 years later, that you at least got 4 years of life. So it would not be fair to compare those patients to any patient with breast cancer, even if you match them by all the different variables that you can think of in propensity score, right? I mean, it doesn't matter how you match them. These patients are just living longer because they are reaching that pregnancy. So we're doing a very fancy matching that is called exact matching. And so the easier way to explain how this works is we're matching these cases of breast cancer patients that achieve a pregnancy to patients that did not achieve pregnancy, right? But the matching happens if they at least lived the same amount of years until the other patient got pregnant. For example, we're matching this patient, this this breast cancer patient that had a date of delivery of July of 2011. So we're looking for a similar patient with similar characteristics based on the exact matching, so stage, age, hormonal status, treatment options, right? But also that patient in the control group have to be able to live until the same, have to be diagnosed at the same month, the same year, and has been able to be alive at the same time as the patient that, at the same time as the patient delivers. So you're presuming that those patients are very similar in characteristics, right? So they're similar in terms of their breast cancer characteristics, but they're also similar in their survival, up to that point. So we're hoping that at least with this methodology, we can account for some of the biases. Because there's no way that you can do a randomized control trial in which you can take patients with breast cancer and tell them, you get pregnant, you don't get pregnant. So we're trying somehow to emulate that with this kind of analysis. Next slide. So next slide. So the other thing that you can look with this data is like OB outcomes. So this is preliminary analysis for patients with cervical cancer. So there are 113 patients that had fertility-sparing procedures for cervical cancer that achieve a pregnancy afterwards. So we are doing propensity score matching. And propensity score matching means that we're doing a logistic regression in which we control for certain variables. And instead of controlling for the outcome, we're adjusting for the exposure. So, and we're matching them to control, two set of controls. The first control are patients that do not have any history of cancer. And the second control is those patients that had pregnancies, but had cervical cancer afterwards. Because those patients might be a little bit more similar to patients that had cervical cancer and then had pregnancy. So we have these, and we do score matching again in terms of certain cervical cancer treatment characteristics. And then we can look at their obstetrical outcomes. So this is just one example, looking at preterm delivery. And as you can see, when we compare the control group of healthy women who never had cancer, and we look at preterm delivery, those patients that had a pregnancy and after that had cervical cancer, the rates of preterm delivery are not different to the control. So that makes sense, right? Because there's nothing you have done for cervical cancer treatment has impaired their ability to achieve a normal pregnancy. But when you compare those to those patients that had fertility-sparing procedures and compare them to those that have healthy pregnancies that are normal controls, the rates of preterm delivery are almost 4 times higher in the group of patients that had history of cervical cancer with fertility-sparing procedures. And this is not new. We knew from before, there's been multiple studies that have shown that these fertility-sparing procedures lead out to preterm delivery, premature rupture of membranes, but it's nice to see that in this large scale, with large numbers, those findings pretty much remain. And that this is important for counseling of patients. Next slide. So, and this is the last couple of slides, so I'm gonna finish very soon to leave for some questions, is that with this database, we know if they got pregnant, we know if they got pregnant, what can happen to their pregnancy outcomes, their oncology outcomes, and that information can help medical oncologists and GYN oncologists and obstetricians to counsel women the safety or achieving pregnancy after these types of cancers. But the other part that we don't have of the picture is what happens to those women that had fertility-sparing procedures or had the opportunity to achieve a pregnancy, but they decide not to they decided not to get pregnant. And when you look at studies, it's actually of the patients that undergo fertility-sparing procedures or have the opportunity to get pregnant after a cancer diagnosis, only 25% of them, so a quarter of the patients, decide that it's safe and achieve a pregnancy or try to get pregnant. So what is happening with the other 75%? So as part of the same grant, we're doing a very large survey in California to really dig into these issues of why women that have the potential to get pregnant after a cancer diagnosis, why they're not getting pregnant. Next slide. So next slide. So for this study we have developed a survey. So we did many patient focus groups at MD Anderson with cancer survivors that are young women with cancer. Some of them achieved a pregnancy, some of them did not, to try to dig into these barriers to achieving pregnancy. And now we have developed the survey, and now we're in the process of validating the survey at MD Anderson. And the plan is by the end of the year, we're going to launch that survey in 1,200 women in the database that we already have, so we can kind of have the whole picture of what's going on. We know their OB outcomes, we know their oncology outcomes, and now we know kind of have a sense of what is a reason of why some of these women never achieved pregnancy. Next slide. And as you can see, these are all the different reasons why women might decide not to get pregnant after cancer diagnosis. Certainly, access to infertility treatments is a big thing. Like money is a big thing, access, fear, uncertainty. So all of those things come into play, but we are trying to quantify what are the most prevalent of those things so we can then develop interventions or help develop tools for physicians to talk to patients about these difficult situations. Next slide. And then just the last slide, I think this is the next one is the last slide. Next one. So on top of that, all of those research, the other thing that we're working very hard at MD Anderson, and particularly at LBJ, is we're really trying to improve access to clinical trials for our patients. So I'm fortunate to lead our research team at LBJ, and MD Anderson has been, and Dr. Liu has been very kind to provide many resources to try to increase clinical trial accrual at LBJ. So right now we have a team of 8, including research coordinators, research nurses that help us in opening clinical trials at LBJ and recruiting patients and enrolling patients for clinical trials, because I think that's definitely another area that it's underutilized among medically underserved patients. Next slide. And I think that's it. Thanks so much. I'm happy to take any questions.
Alejandro, that's mind-blowing, I just got to say. And the fact that you're doing this work at an institution that is so supportive makes me feel hopeful.
Yep.
This is such an important topic. Now, I know Lisa Barrelette's got a question for you, and her WebEx is frozen. So let me see if I can. Oh, here we go. Let's start with something from Ryan Spencer. We have smart young residents and fellows interested in research and advocacy in health disparities. Could you offer some advice on career steps that activities that would be, oh, I can't read it, but would be helpful to these folks?
Yep. I think that's such a good question, and it's coming from, that's such a good question. And I think there's, the good news for residents and fellows that are interested in the topic is that this is an area that it's wide open for everyone to really join in and do research. So there's definitely a significant need. I would say that in the past, and I'm included, we were very focusing on just describing these disparities. And I think at this point, we all know that these disparities exist, and they're prevalent and they're common. And I think COVID has shown us that it's, have opened the eyes even to more people. So my suggestion, if I was able to go back 10 years, I wish I would have started to think about interventions and how to really move the needle instead of only just describing them. And certainly doing interventions and doing this, it's a much harder and takes longer. But I think at the end, to be honest, it's a much more meaningful work than just taking a database like I've done in the past and just describing them. So I think if you guys, and I'm sure they're young, smart, I would say if you really want to move the needle, think about not just describing, how you can create interventions to, again, move it forward.
Thank you. At some point, you just get sick of talking about it. Let's do something here.
Exactly. Yes.
Yeah, thanks, Alejandro. I appreciate that, and I got to tell you, I miss you. Wish we're still with each other, but
I know.
I really appreciate that, because I've already got some texts from residents today inspired by your talk and wanting to do just that. So thanks for chiming in about that. I appreciate it a lot.
That's very kind, and I'm more than happy if there's anyone interested. And I know I talked a little bit fast and I could not go deep in some of the studies, but I'm more than happy to talk to anyone who's interested in this. More than happy.
Thank you, Alejandro. And I've got somebody I want to hook you up with. I'll text you after this. Lisa Barrelette has a question. Has Alejandro noticed that male relatives are less likely to get cascade testing? This has been a struggle, especially in rural communities.
Absolutely. So that's such a good question, Lisa. Yes, and so for our study on that we're doing the interviews, we're actually including male and female family members because I agree with you. There's data that males undergo genetic testing less often than females, and I think it's very likely that males will require different interventions than females in order to get testing because it's not in the radar. So yes, I agree with you.
Yeah. Okay, other questions, other thoughts? We've got about 2 more minutes. Alejandro, this may seem completely tangential, but do you want to say a word about this Lancet trial?
Yes, sure. It's it's a very separate topic.
Yeah, it's totally different. Sorry, I digress.
So we are doing a randomized controlled trial in ovarian cancer. So we are for patients that receive neoadjuvant chemotherapy. So patients with advanced stage disease that are deemed or the physician thinks that are eligible to receive neoadjuvant chemotherapy. They receive 3 or 4 cycles of neoadjuvant chemotherapy, and they have a very good response based on imaging, but they have to have a normalization of their CA-125. So we're picking those 20% of excellent responders to neoadjuvant chemotherapy, and then we're randomizing them between open surgery, that is the standard of care, and minimal invasive surgery. And I think this is an important trial because when we have looked at the data nationally for the National Cancer Database, right now it seems that around the country, of the patients that are receiving neoadjuvant chemotherapy, 25% of them are already undergoing minimal invasive surgery. So I do think that it's more common than we think, and I think my feeling is going to be very similar survivals between both groups, but a recent trial in cervical cancer has proven us wrong, in which patients for cervical cancer had worse survival. So I think this is going to be a little bit different story. That's my feeling. But I think the important thing is that surgical trials in GYN oncology, but I think in GYN in general, are so important. Are very difficult to do, but they are so important. And I really appreciate your group, Lisa and Dr. Rice, just really for the support for this trial, and all the GYN oncology department really for being agreeable to participate in this study. And we had the first patient randomized to the trial yesterday, so it's exciting. So hopefully we're
huge congrats. And then I'll wrap up by just stating you're being very modest, Alejandro. That paper that you and Pedro published regarding minimally invasive surgery with early cervical cancer has been a game changer for the field, recognizing that survival rates are not as good. So major kudos, and so happy that you presented that at the SGO meeting that you did.
Yep.
Now, I just have to say those kids are pretty adorable. And any other questions or thoughts for Alejandro? Okay. Hey, listen, make sure you say hi to all the peeps, and we really appreciate you doing this. Thank you so much. Have a good day, everybody.
Bye, take care. Thank you.